Hello, friends. So, um, we feel that palliative approach to care and long-term care is really probably the most essential bit of what we do as teammates um, every day. I think we want you to leave today's session really understanding, a few key things about how to approach to care and long-term care. And I think the biggest thing, I'm not going to put on the slide, is that we 100% believe that every decision, every interaction with patients, everything we do in long-term care is founded in the idea that this is their home, this is their last home, and that everything has to have the lens of palliative approach to them. Really, it's like drinking the Kool-Aid. We have, we're singing to the choir here because you're all here to learn that and you already live it and breathe it. But I'm going to dump a bucket of Kool-Aid over you to really drench you because it is what we do and we lean into it super strongly. And so really, if you just leave here with that knowledge, and we'll give you some tips along the way, but really, if you leave here knowing that, you know, palliative care is everything about long-term care, that they're integrated, lockstep, then that's the most important thing to leave. I'm gonna pass it to Laura, to lead us through some of the introduction stuff and the nitty-gritty, but that's just my overarching big vision to share with you. And yeah, so Laura, you want to take it over? I think you're on mute still, sorry.
That's so embarrassing. So yeah, when we talked about what our objectives would be, these are the ones that we came up with, sort of broad strokes. And as Nick said, it's really about the fact that our entire lens is focused on how we can be approaching a patient's entire care plan on palliative approach. Once they get to long-term care, things really shift. So we'll talk throughout the presentation about the Fraser Health approach, how that's kind of gone historically and where we're at now in terms of the way we're doing things. Fundamental principles of palliative approach to care in long-term care. And then we'll kind of highlight a patient's journey in long-term care once they arrive, and then how does it look and how do the pillars of palliative approach to care apply to a patient in kind of day-to-day life, and how we care for them in kind of a structured format that allows us to really focus on palliative approach to care. So those are our objectives today. And oops. So I think we'll start with a poll. Our two questions are, how much do you know about palliative approach to care in general? And then how much do you know about long-term care in general? We'll just get a sense of where people are at in that. All right. Okay, so it looks like most people are at least somewhat knowledgeable about palliative approach to care. There's one person who doesn't really know at all, and then very knowledgeable is kind of a third of people. And in terms of long-term care knowledge, we've got about half who kind of know something about it, one who doesn't know anything, and then about, again, a third who really know what it's all about. So just for us to kind of have a sense of who we're chatting with. So that's good to know.
Let's hope that people can give us some tricks today. I like this.
Yeah, that's right.
Yeah,
exactly.
This is not just for you. We want to steal some info.
That's right. Okay, so next. All right, so we'll pass it over to Nick.
With that being said, what is long-term care? Almost half of you know about long-term care, so we won't try to belabor the point. But a lot of the misconceptions and myths out there, we're going to try to break down very quickly. I've already said it. People move into long-term care and they don't move out. 15 years of working in long-term care, how many thousands of patients I cared for because I have like 100, 150 at a time. I can count on two hands how many people left to go home. And most of those folks went to go home to have palliative care. So people are moving in and they're staying with us, and this is their last home. Um, Long-term care is 24-hour supervision, not 24-hour care. A lot of families and patients think I move into a care home, I'm going to have a nurse and a care aide right there at my bedside like a butler, at every moment. No, it is 24-hour availability. It's supervision by the nurses on site with availability of the care aides that provide that personal care. Some of you might know, but long-term care is funded at 3.26 direct care hours per patient per day. Gita might know the exact numbers if that's changed, up to 3.4 or something, but that is how much actual care somebody receives, in theory. Now, some people get more and some people get less, but it is not 24-hour care. It's 24-hour availability of support. And it's really for those unscheduled care needs. So as you think about what's the difference between assisted living, independent living, home health, supporting you at home versus long-term care, it's that in long-term care, you must have unscheduled care needs. And what's unscheduled care needs? Having incontinence, falling down, having, breakthrough pain that needs a medication, needing a puffer for your COPD and you can't access it easily. That's unscheduled things. If you can schedule your care needs, somebody providing a meal, feeding assistance, having a shower, that can be done in assisted living. It doesn't need to come here. So really, it highlights the fact that somebody has to be pretty darn frail and pretty, high care needs to be in long-term care appropriately. Just for some basic stats, like the average age is 85 years old. So we don't have folks that are, in their 70s pretty much. And the vast majority of folks have dementia and will need to have a special type of care where we understand that they're not able to always direct their own care and say what they need. Next slide, please. So just high level again, who are we supporting? There's 30,000 residents that live in long-term care across BC. There's 6,000 people waiting to go into long-term care. That's the most staggering bit. So we have 6,000 people who are very frail living outside of long-term care that need to be in long-term care. So this is a broader, discussion in the sense because those 6,000 people are going to be cared for by lots of acute care teams, home health teams, community teams, and you might be coming today from one of those positions. And so understanding how to support your patient if they're one of those 6,000 as they enter long-term care is also very important. And also, we need to talk about palliative approach to care philosophies way upstream. So those 6,000 people, I feel, are getting a disservice typically because they come into long-term care and they have no real understanding about the truth of the situation, their frailty, their prognosis. So if I can put that in your head today, if you are, a part of a nephrology team or a home health team or wherever you work, I hope you can do that. We work in Fraser Health, and just our stats, because we have better access to those, 8,700 people in long-term care, 1,500 waiting, and the turnover is immense. We had 4,000 people, admitted on average over the last couple of years. So the turnover is almost 50%. You can understand that this is not a long length of stay, and the average length of stay is 15 months. Averages are sneaky. If you know an accountant, you know that you can manipulate averages. So a lot of our folks are going to pass away within, 9 months. And then a couple people with, early onset dementia that have the rest of their body healthy, they're doing 20,000 steps a day walking around. They live for like 3 to 5 years and they bump the average the other way. So 15 months, I'd say that as they're walking in the door, there's a really good chance that they're not with us in 6 to 9 months. And we have to take that approach to every patient that walks in. This is their last home. They need to be supported in their, chronic disease in that way from day one. And as you guys have all drank the Kool-Aid of serious illness conversation probably and stuff, the tagline from that, I hope for the best for your loved one, but let's plan for the worst. So let's hope for the best that this person is going to be with us for many months if that's their wish. But let's plan for the worst that they might only be here 3, 6, 9 months, and let's get palliative approach going. Next slide, please. And over to Gita.
Thank you so much, Nick. Hi, everyone. So I'm going to talk about why is palliative approach to care is so important for us in Fraser Health long-term care. Because as Nick and Laura said, we believe this approach meets the residents' healthcare needs with serious illnesses, including dementia. And we really think it supports families or residents throughout the illnesses, not just at the end of life. It supports our staff to ensure residents' pain and other symptoms are very well managed, to provide holistic and person-centered care, and as well as mental health support. So overall, we think palliative approach to care main goal is for residents to feel more comfortable and have better quality of their life. And why it's important for long-term care population? Because long-term care home is home for many of our residents with serious illness condition. And those serious illness condition cannot be cured. Dementia is a key example of that. And as many of our residents in long-term care have dementia. So next slide, please. So for us in Fraser Health and in Fraser Health long-term care home, we implemented palliative approach to care many years ago. I guess it was a few years before even COVID. So the implementation process started with leadership engagement, of course, like any other initiatives. Then the required education was provided for all staff, so including care aide, including our physician, families, and residents. We created many standard regional tools and resources, such as SBAR communication with physicians, clinical practice guidelines, actively dying protocol, pre-printed order, pain CPGs, advanced care planning policies. So many regional tools and resources were created. And we ensured palliative approach to care is included in the staff daily workflow. That one was the key, to ensure the routine practices have palliative approach to care component. We didn't just provide education and leave. No, we ensured those components, those pieces of the puzzle are included in the staff daily workflow. And also, we ensured palliative approach to care was included in residents' assessment, monitoring, and care planning tools. Evaluation, in order to evaluate how effective this tool has been, we use neighborhood audit tool at the care home level, and also we have quality partner audit tool at the care home level. Additionally, we have at the regional level, we have clinical quality indicator to help us to evaluate and assess how we are doing. Can I go to the next slide, please? Sustainment. For the long-term sustainment, we have some activities in place. For example, we have community of practice meetings to share the success and challenges with each other. We also have ongoing collaboration with Fraser Health Palliative Care Program, Advanced Care Planning Program, and at the provincial level, we have a connection with provincial palliative teams such as BC Center. We are ensuring palliative approach to care philosophy is included in all initiatives and all new decision support tools that we are making. So as Nick says, it's not just a standalone project, it's not a standalone program, it has connection, strong connection with the all initiatives that we are doing in long-term care Fraser Health. And also we are monitoring data on an ongoing basis. We are revising tools and processes and resources as needed. We are providing palliative approach to care refresher education as needed at the care home level to make sure everybody has education, new leadership, new nurses, new care aid are on board. Thanks. I guess I'm going to pass it to Laura. Thank you.
You know what? I think is this Nick?
Yeah.
Oh, I'm
this
sorry.
is my one. That's okay.
Okay.
So back to the basics a little bit about palliative approach to care. There's lots of different versions of what the pillars are. We sort of work with 4 pillars that we think about in Fraser Health in this, clinical assessment being the first step. Later on in some slides, as we get to the the nitty-gritty of how we do this and incorporate it into the daily workflow, which Jody asked about in the chat, you're going to see some letters next to the workflow things like A and P, and it just is going to tie it back to how that daily workflow comes off of the pillars. So clinical assessment, that's one of the foundational things. We need to notice something's changing, notice something's happening in order to provide palliative approach to care. And so two key things that we integrate into our work at a systems level is going to be identifying the life-limiting illness and then identifying symptoms and suffering so that we can act on those. And when we think about long-term care, we already gave you the stats. People are living for months. They're coming in very frail. These folks all have life-limiting illness from that whole serious illness approach. Like that's what we do as clinicians is say, do they have a life-limiting illness? Nobody needs to ask that question. When they move into long-term care, they have a life-limiting illness. They probably have 5 life-limiting illnesses realistically. So that's why it's every moment of every day for us, because everybody has multiple life-limiting illnesses. So then when you have done your clinical assessment, that gives you information to do a prognosis assessment. We have to understand what is going to happen in the future, how that is going to change, how quickly do you intervene, and give some education later on. So we love the idea of the illness trajectory, which we have on the slide here to the right. So that graph that I'm sure many of you are familiar with, that just talks about how the different life-limiting illnesses will change over time. The easy example is the difference between, say, cancer in the blue and frailty dementia in the green. With cancer, your function is pretty fair until all of a sudden everything fails. And for dementia, it slowly declines down. So we keep that in our mind as we talk about things with families and as we go and provide the next pillars. And the next one we go on to, you can go to the next one, sorry, is communication. So now we have an assessment. We know what's going on for them. We understand where they are with their disease, what's likely to happen. Now we have to share that with our teammates, and we have to share that with the residents and their families so that we get on the same page. And that happens, at the core of what we do is we can't just keep that info to ourselves. We have to share that. And the last bit is about symptom management. We do all the other work, but we have to make sure that it results in them having a care plan and a disease that is as comfortable as possible for them. And when we think about things in long-term care, it's way different than, say, the community. We have a care plan, as we talked about, where we provide direct care to them. And so often symptom management falls down to, I have a pain, I get a pill. It's way broader in long-term care than that. It's everything that they need, we provide for them if they need it. And so when we think about symptom management, it's much broader to a care plan, their activities of daily living, their social comforts, their connections with others. So it's very broad when we think about symptom management. And Laura will get to that in the next couple of slides. Next one.
Yeah, so I think we've sort of touched on this concept, but just to outline it like super, super clearly, we think of the foundational principles of palliative approach to care in long-term care as the following. So these are always at the top of our minds. They shape every decision. They are the lens through which we provide care, essentially. And that, again, that goes for all care providers. That's not just at the top level or the doctors or the whoever. It's filtered down through the entire care team, in theory. So we want to establish comfort, care, connection, and we feel that that is what means that we are ensuring we're focusing on quality of life, no matter what else is going on medically. So even if we're treating medical issues, we're still focusing on comfort, care, and connection. Comfort being, of course, that they're comfortable from pain, from symptoms. We're caring for them to meet their specific needs, and we're allowing them to develop an established connection to others, to family, to whomever makes them feel good. And this is like the pinnacle of what we're aiming to do all the time. The second one there, our care is always palliative care. So even if the family's not aware of this, or the loved ones or the patient themselves, with that shift into long-term care, as Nick was saying, you have to be pretty frail to get there in the first place. And so from the care team perspective, as soon as there's an admission to long-term care, that generally comes with a shift in the approach, the mindset, and we start to focus on quality of life above all else. Again, even if we're still actively treating other medical issues at the same time. Number 3, the resident and family are always involved. That's quite different from, you know, an acute care admission, for example. We attempt to involve family and resident in everything, unless there are cases where the family, you know, they've said we don't want to be involved, just do what you think is best. But for the most part, we're involving family and the resident as much as we can in the care plan. They're also part of the care team often. They provide lots of, you know, additional care for the patient, you know, extra visiting, and sometimes they're part of the wound care or things like that. Not formally, but they become a real part of the care team. And then at our core, we're always asking ourselves, what are we trying to achieve for this resident? At every step along the way, this question, we try to keep it at the top of our minds. We do this so that we ensure ongoing alignment with their goals and their quality of life. We revisit this question constantly, especially with the resident and the families, because the default tends towards escalation or intervention. And so we're always pulling it back to, well, what are we actually trying to achieve? Oh, should we do blood work, doctor? Oh, well, okay, we could consider it, but what are we trying to achieve with that blood work? Because we are poking them, we're putting them through some discomfort, then we're discovering something that might be wrong, and what are we going to do with the answer? All these types of things, we try to pull it back to that kind of baseline question.
And it's interesting. I just finished an hour-long family meeting where that last line was the theme of it. The patient had likely a stroke last week. The son was at bedside and talked to me last week. I walked him through. Yes, he probably had a stroke. What are we going to do? Here's the options. What does going to hospital look like? What does getting a CT scan look like? What does staying at the care community look like? So we had a follow-up this week. The daughter joined, and she said, well, does he need a CT scan? We went over it again. Every moment it's asking that question. What does that test achieve? What does that change to the care plan achieve? What does a seating, you know, change to the wheelchair achieve? What is going to focus on that resident and their goals and their wishes? So there's a living proof of how that question comes into play every day. We're going to switch it into now getting very practical, the next series of slides. I know you've been waiting for this anxiously, because I'm sure you all agree with the philosophy we just proposed. We think of the patient's journey, the resident's journey in long-term care in 4 kind of buckets. There's an admission process, which is quite a whirlwind for them. They're moving into their new home, and they never wanted to come to long-term care, because I've not met somebody yet that wants to live in long-term care, you know, if they could choose to. Then, after they get settled with the admission process, we had to do constant proactive monitoring of them. Everybody on that team, care aides, social workers, OTs, PTs, physicians, nurses, everybody's doing proactive assessments constantly. Then they have an acute illness. They get better, they get worse, they pass away, they live, and then they have the actively dying. Because as we said, everybody moves in and they're staying with us until they pass away. So when we think of the 4 A's of the patient's journey, we're now going to break down how we integrate the pillars into the day-by-day life of a care aide, a physician, a nurse, and a team member. So I'm going to pass it to Laura to go through those 4 parts of the journey and how we incorporate things.
Okay. So yeah, as Nick just outlined, we start with admission. And as he mentioned before, the little block letters to the side kind of relates back to which pillar of palliative approach to care it kind of correlates to. But we wanted to take you through kind of the tools that we use in long-term care on a day-to-day basis. So we start with a moving in day interview, and it's a really big day for everyone. You meet the family and resident, you address the details of their care requirements, you assess function, and then there's communication with the family about what long-term care is and the logistics of care, what's offered. And this involves a variety of team members, the social worker, nurses, family, Generally, I think the doctor's involved, but all these other people are involved in getting to know them and kind of getting a sense of who this person is. Part of admission is also determining the substitute decision maker. And as we all know, that's an important aspect of their care because that's who we'll be kind of dealing with if the patient isn't cognitively capable. So that's something that we prioritize as a tool. And that typically is involving the social worker, the nurses, the family as well. Clinical assessment is done by the whole group of different health care providers. So, through this, we're assessing their medical, their social, their cultural, their recreation, histories, ADLs, all those types of things. And of course, it's not just, on admission, but ongoing, but it's a starting point that we start at admission. And that's, as I've outlined there, that includes the whole care team. And all of those so far are kind of part of the assessment part of palliative approach to care. Another tool we use is medication review. So this is an initial assessment done by like pharmacists, nurses, family doctor, and hopefully we're aiming to assess whether their symptoms are managed properly through medicine. Are there preventative meds that we could consider getting rid of? Are there things that they're missing? Things like that. So that's just sort of an initial assessment. And then we also aim to see if there's been previous goals of care conversations. That's not always the case, and we can't always access that information, but ideally we get a sense of if this is something that's been discussed ever, or if this is going to be a new topic. And that involves those team members listed there. And that includes that sort of part of assessment and communication with the family. So I put this there just to say, again, like to reiterate that all of this is done on the foundation of remembering these principles that we talked about already. So nothing is done without that entire kind of lens. So next we come to proactive care, which is what Nick had mentioned. So this is sort of day-to-day care, aiming to keep them well as long as possible. So that includes the tools we include in that are daily personal care. So that includes monitoring their basic functions, bowel function, behaviors, sleep, symptom management, all those types of things. It also includes connecting annually. Oh, sorry, I didn't want to go there yet. So it also, yeah, so sorry. It also includes assessing them fairly, like regularly throughout their care. So we're doing their day-to-day care, and then we're also assessing them for any changes or differences in things. They're again assessing their ADLs. How are they eating? How are they getting around? Are they still able to walk? Do they need mobility assistance? Things like that. And then part of this is also an annual care conference. So we do that once a year. That involves a whole team of people. We go through their goals of care again. We talk about prognosis, medications. We assess them on the frailty scale tool, which helps us to determine prognosis or kind of reassess prognosis. We again review ADLs, and we talk about living at risk. Again, like what's most important about this annual care conference is that the whole team is together, but importantly, ideally the family's involved. So if there's no other time during the year that you get to sit down and have an entire conversation about how things are looking for the resident, this is the time that it's done. And it's not like everything can definitely be talked about, but we can talk about the big bullet points. And from the care team perspective, the goal for us is really to say, how are they doing? What has changed? How can we update this for, what they seem to be kind of hanging in there, doing much the same. So the idea is not to talk about every little minute detail about what are they eating every day and did they, go to the bathroom yesterday? The idea is to say, here's how they're looking. Here's the updated prognosis. with that in mind, do we want to change their goals of care? With that in mind, so should some of these medications be removed? For example, do we still need their statin for primary prevention? Things like that. And it also allows us to say, living at risk is one of these questions where patients, for example, somebody who might have had a stroke and the resident is really insistent that they want to keep eating, even though it might not be deemed safe. And we get to say, listen, what do they want? What are their goals? If their top priority is just to enjoy food, is that something they're willing to risk? And if so, fair enough, because maybe they have 3 months left. Or are they somebody where they're really wanting to prolong life as long as possible and therefore don't want to take any risk? And so where do they sit in that spectrum? So it's sort of like a big picture conversation. And the idea is to communicate, to get an updated prognosis, and to make sure symptoms are managed. And then, of course, we're always, again, focusing on those foundational principles. Okay, so then we come to acute changes. So this is obviously where things have changed. We're doing our clinical assessment. The various team members are doing that, the care aides, the nurses, the family doctor, the dietitians, and assessing symptoms and comfort. We're always wanting to prioritize those things, as we've said many times. At this stage, we do our best to determine or assess the state of their illness or change in their health status, and then determine what treatments are available based on this and where they are in their health trajectory. We use a few different tools, for example, the clinical practice guidelines. We use a prognosis tool. We use the frailty scale to help with this assessment. And then we update the family and say, here's, not update them, as in have a conversation with them. We share the updated prognosis. We discuss what are our options. We discuss how can we keep them comfortable regardless of what's going on. How can we keep their quality of life high, again, regardless of what's going on. And then once we've determined the goals for the patient in terms of what we want to achieve, we focus on an updated care plan. So then we're saying to ourselves, are we just focusing on comfort? Are we focusing on an escalation of care, like to acute care? Are we allowing transition to end of life based on these goals of care discussions? No matter what, again, we're focusing on quality of life throughout. So if we can keep them comfortable and make them comfortable throughout this, we do. And then we move to actively dying. So if we're in a scenario where either we've discussed the acute changes and we've decided on actively dying, or if we know that this has been just like a slow, steady progress towards end of life, this is where we land. We know that by lots of different things, assessment that shows us decreased intake, they're sleeping more, they're not as alert, they're just not behaving like themselves as they usually are. And at that point, we talk to family, talk to them about the transition, and we get the staff on board in terms of, we're all going to be giving consistent care now that there's been a shift to end of life. We now, of course, focus on symptom management. So we use actively dying orders. That includes stopping vitals. We focus on medications for symptoms. We try to make the room comfortable. We allow the family to visit as much as they need. We provide grief support, all that sort of typical end-of-life stuff. And we also increase the frequency of assessments as well, meaning we're not just popping in on them once a shift. We're making sure actively, constantly that things are managed. If they're having pain, if they're having shortness of breath. We also focus on the fact that we are experts in end of life symptoms and the process that happens. A lot of families will say, oh, now that they're dying, do they need to go to hospice? That type of question, or do they need to go to palliative care? Not really understanding sort of how the system works. And my first thing that we say is we do this all the time, all day, every day. We are helping people transition through end of life. So we certainly focus on making sure that staff know how to manage these things, how to provide medications as needed, and certainly not to hesitate giving medicines if there is the signs of discomfort and things like that. And again, we're always remembering those foundational principles. So I'll pass that back to Nick.
So nothing's easy in life. This has been a long road for us in Fraser Health, from like the cutting room floor of what are we going to do, and turning into a program that has sustained for a number of years now, and is broadly used across our 80 care communities that we support. So some of the challenges, along the way, and in sustainment, really has been, as anywhere in healthcare, there is frequent team turnover. So we do education, we build in things into our workflow, and then somebody new comes and it's not part of their workflow as a team member. We had to constantly keep the foot on the gas pedal to do that. That's just even just the interdisciplinary team. When you have leadership turning over at a site, that is probably an even bigger disruptor, because they're the ones that are going to say it's okay to take the extra time to do palliative approach to care. And so we have to continue to check in with the leaders as new leaders come and educate them about what this is about. Beyond that, you have to have the systems level understanding that palliative approach to care is important. And so we work hard at our higher level meetings and leadership teams to have placeholders on agendas for palliative approach to care. I think it took years to do it, but now we have tons of people reaching out to us that are updating a clinical practice guideline or something, and then they say, want to make sure that this fits with palliative approach to care, and they'll send an email to Gita or Laura to say, just look over our COPD protocol, because everything we do is palliative approach to care. COPD is a lung disease, but we need to make sure that we're not going to do something that totally doesn't make sense. That's actually an acute care driven thing or a community driven thing. So we've built that in, but it took a long time. And we were allowed to do that because our highest levels of leadership supported this in and out every day. So I think that's really where it starts at the top. If you have leaders that want to do this and then allow you to have the time and the place for it. And then you have to go beyond just a health authority or a network. Is, provincially and nationally, we need to have organizations make time for this. And that's why we're so thankful, for the BC Centre for inviting us today and saying this is important, because it takes, those high level organizations to think that this is important. And then you have to get ingrained into guidelines, and it's been, moving into that way. Certainly, if you look at some of the national physician guidelines, like the Choosing Wisely guidelines, they do talk about, palliative approach to care within their guidelines. And then within your own, world, there's other partners. They're not long-term care people themselves, but they come in and work with you. So infection control is a common one. Like, oh my goodness, they have a set of beliefs and protocols, and it's just, we need to make sure we have our hand hygienes and audits. And yes, that's all very important. But they have to come in and recognize that this is a unique place. And so you have to partner with those groups, and you have to have them understand why they might have to adjust their expectations for the world of palliative approach to care. And it is not easy to do palliative approach to care because, it's much quicker to do default care. Send to hospital. Don't pick up the phone and call a family. Don't ask the resident what they want. Don't look over their medications. It's easier. But it's not the right road to take. And so that's probably the biggest thing, is trying to get people to buy into that this is the right thing to do. And when they've done it a few times and they understand that, yeah, it is the right thing to do, and they feel better about their work because of it, then they'll keep on going. But it's hard at the beginning to change that from default care. And it's tough during times of crisis or, low staffing for people to want to take the extra bit. But those are the challenges so far we've noticed.
Yeah,
Laura.
and so, we come back to our objectives, and hopefully we feel like we've talked about these things. And mainly the sort of our Fraser Health approach, our fundamentals of palliative approach to care in long-term care, and then how that looks for a patient day to day, and how we apply those principles to their care.
Yeah, thank you
That's it.
all. I see that we are at about 12:45. I was just wondering if we could use some of this extra time to ask questions for Ita, Laura, and Nick, if there are any, and then potentially just have kind of a bit of a group discussion. And yeah, thank you so much for sharing those experiences. And I know from looking at the participant list, even and being in this work for a bit, I know that a lot of these teams are right in this mess as well in terms of implementing this approach in long-term care. So curious if there are any questions, and we can kind of share some learnings about this work from participants. So feel free to put a question in the chat or raise your hand and ask the question and unmute yourself. Just wait a bit, and if there aren't, I have a question, so jump in.
I have a question. I work in an outpatient neurology clinic, and over time, our patients do enter long-term care facilities. And I guess as listening to you today and listening to a lot of the caregivers and families who are navigating once the patient is already admitted, how can I best prepare them for, the caregivers? How can I best prepare them and the families for navigating how the care is going to look in any given facility that they go to? Because I certainly am frequently on the receiving end of their calls where they're frustrated because they wish that more was being done, or that the resources in the care facility are not meeting their expectations. Not saying that they're not meeting needs, but certainly. So I have a sense you're getting the gist of what I'm saying.
Yeah. I think you answered the question for yourself in the words of expectations. That is the biggest disconnect, is that the world has a set of expectations for long-term care, and we are not staffed to meet that. And so I think, us sharing a couple of the common myths that families come in with, and then you can try to debunk those myths in advance, is going to be the best thing. So I said it in the first couple slides. A lot of people think that it is 24-hour care, and that if you hit a call bell, somebody's going to come within seconds. Of course, the aim is to support somebody ASAP, but you have one care aide for 8 people, and that's during business daytime hours when people are up and awake and needing a lot of care. And the ratio is more like, Gita can speak to it better than me, but like 1 in 15 overnight. And so you're going to have to wait sometimes. And sadly enough, if 3 people need care at the exact same moment, it can be like 45 minutes, which is really saddening. And nobody wants it to be that long, but it is just what the fact is. So families understanding that the care is supervision and not direct in that moment. I think the other thing is going to be just the principles of palliative approach, that long-term care is about comfort and not about rehabilitation or getting better. I don't use that word to families, but nobody's getting better here. You come to long-term care because you have no prospect of getting better. If you can get better, you go to a rehab site, a convalescent care site, you stay in acute care, you stay at home. Like, we have thousands of people waiting for a bed in long-term care. So if you are going to get better, you do not need to come to long-term care. And the health authorities and the Ministry of Health have poured in enormous resources to support people to stay at home and to go to places like PATH units and ALC units and convalescent units. So when you get here, it's because of a strong reason. I think that's the disconnect, that a lot of families think that this is some kind of like bridge or temporary, or you're going to get better, or you're going to get daily rehab, especially folks that come in from acute care. They're expecting daily physician rounds, nursing ratios of 1 to 4, care rate ratios way higher, daily physio, OT, that kind of thing. It's just, this is a home. And so when I tell people, it's, how often do you see your family doctor? Once every 3 months? You might see us once every 3 months here. How often do you see your community health nurse? Well, you're going to see them more, but it's that kind of sense. And people need to understand it's not acute care, and it is their home, and it's staffed to provide comfort and not heal them. I think that if you can get those couple of myths across to folks, it's going to be very important in that
I
way.
think you raise a really good point, which is saying this is their home and how often do you see your GP? Because I think they really do go in with this expectation that they're going to see the physio, see the OT, you know, with frequency, and that if they were living at home in the community, they would not be seeing these people. So I think a lot of work to be done in kind of preparing people. I think the catch-22 is that then people say, well, I think he's going to get better care from me at home, yet the resources are really not there to then make that happen. So it's really tricky. But thank you for your,
Very sad.
I appreciate that.
Gita,
Yeah,
what are you going to add? Oh,
sorry.
Nora, sorry.
I was just going to say the exact same thing, and then you said it, but about you think of this as your home. So if you were going to see your family doctor, you'd book an appointment. You might not see them till 3 or 5 or 7 days from when you call. And that's the equivalent of what we're doing in long-term care. But I do also talk to families about that gap where I think our system doesn't have a good space for the people that aren't quite bad enough for long-term care, but are not getting their care needs at home. And I kind of just empathize, like we're kind of stuck in a non-ideal scenario where we have long-term care that really is for those who are super frail, and we're not getting, like, I think maybe people see in the movies that you go to a long-term care location and yeah, like you're waited on hand and foot, and that's not what we have. And then at home, they're not having their care needs met, and there's this gap, and it is frustrating because it feels like that gap needs filling. And I do my best just to say, like, you know what, we're not in an ideal scenario. Luckily, your loved one has so far been able to be cared for pretty well. Now we're kind of getting stuck in this middle space, and we're just going to kind of have to work with what we've got. And sometimes that helps them to kind of feel a little bit more like, yeah, you're right. It's not perfect. We're not in a perfect system. We're in a scenario that's not ideal. We have an aging population that doesn't always fit in one place or another. And so I try to just kind of connect with them on that level. And often I find that they just feel heard in that sense. Like they're looking for a little bit of like empathy or a little bit of kind of just, yeah, you're right. It's not ideal, but we're working with the system that we've got. And that sometimes helps to make people feel a little bit better.
Thank you, Laura. If I can add just a tiny bit of information, totally agreed with Laura and Nick. What I'm experiencing every day almost is family don't retain the information when their loved one is coming to us. I think it's a stress, or I don't know what is going on. You know, they don't retain the information. It doesn't matter how many times we explain about what do we have in long-term care, what we can provide. They don't retain the information, and that's why we did some activity. For example, we made a booklet to help them to review the booklet over and over to understand what is provided in long-term care. And the other thing we have is we inviting them to have a tour before coming, you know, the loved one coming to us. Those activities sometimes is helpful, but not all the time. So Elaine, I can relate to your question that family is having difficulty to understand what we can provide. Thanks.
Yep.
Great. And some great kind of comments and questions in the chat about kind of staffing and more about kind of managing expectations, and also just wanting to acknowledge that, yeah, our health system isn't where we want it to be. And sometimes the quality and delivery of care isn't what we want it to be. And that can be hard, obviously, for patients and families, but also as providers, kind of having that gap in what we want to provide versus what we can, and just acknowledging that that's a tough space to be in and work in. And then hoping, Marlene, I see that your hand's up. I think we have time for one more quick question. So thank you.
It's more of a comment. I know in Thunder Bay, we have limited transitional care unit with beds that are occupied by people waiting for long-term care, but not sick enough to occupy an acute care bed and not maybe meet the requirements of the rehab hospital in Thunder Bay, that then they transition into the long-term care facilities from there. But once again, they're limited beds. And I have to agree with the other, I can't remember the person that was saying it, about how family members seem to have a different view once their family members are in a nursing home or a long-term care facility. That I have to agree with you that they see things in a different manner after their loved ones are transferred to long-term care. That how come all these issues that they were experiencing at home haven't been addressed, or how come now they notice them more so in the long-term care than when they were taking care of their loved ones in their home.
Yeah.
It's that transition that takes, I'd say, families just as long to adjust to that transition into admissions to a long-term care facility, of at least 8 weeks to get used to how the facility works, how the staff work, how the system in it just works, and how they've adjusted both, not just the client, but the family members to that one guilt that they're putting them in a nursing home, that they weren't able to care for them along that journey of their loved one's decline.
Yeah.
I think that is a very important point, that let's recognize you move into long-term care almost always. You've been at home with a life-limiting illness, and then you go to hospital with that illness flaring, and then you get the sad news that you're not coming back home this time. And that family who has provided all the care for years and has been the doctor, the nurse, the care aide, social worker, physio, all those jobs, now has to hand that to somebody else that they've never met, that likely there's some antagonism because the system sets it up to be antagonistic about you have to go to the care home, you're not allowed to do this and that. You never get to the care home you want to get to. And so on that first moment of that relationship, they're entrusting a whole brand new set of teammates with that. And it takes, as you just said, it takes weeks and weeks for trust to be built if it can. And any little bump in the road in that first couple of months breaks all the trust. And for a lot of times families really understand the person's care needs very well because they're the loved ones. They know their wishes, beliefs, culture, all those things. And so that is a really rocky time. And I think that's why we need to include as many, as often as we can, families into that conversation. It's a tough bit, but yeah, I agree with you. Thank you for bringing that point.
Great. Yeah, and just kind of from the chat, sounds like there's lots of discussion and want for maybe a part 2 or kind of further discussion on where to go next. So that's just something we'll definitely take forward, and we recognize that there is a growing need to focus on long-term care. Probably always has been, but maybe we're just hearing those voices more and recognizing that as well.
Right.
Just also wanting to recognize that it's 12:58, so we're nearing the end of our session, and everyone probably needs to get back to their respective activities. So we just have a poll that we encourage you all to fill out. This is really helpful feedback for us, and they help us kind of plan the rest of our sessions for the upcoming years. So invite you all to complete this poll. And then also just wanting to do a quick plug for our All Together Symposium, which is happening October 4th, and registration is still open. I believe it will be open for another week. And there's just a slide where I'm just wondering if we can jump to it. I think it's at the end here.
Sure.
That just has some information about our symposium. Oh, maybe we don't. Esther, do you mind just putting some info about the symposium into the chat if that's possible? But otherwise, thank you all so much for joining us today.
Thanks for having us.
Thanks, guys.
Yeah, thank you. It was a great session.
All right. We'll stop sharing now.
Yeah, that's great. Thank you. Thanks, Esther, for doing that. Great.
And Laura, can you send out the recording?